Well, again, my name is Alex Vasquez. I appreciate the generous introduction there. And today I have the pleasure and the honor of going through some of my favorite material with you, which I enjoy doing very much, especially when I get to present this material in context. For example, last year, towards the end of the year, I gave a part of this presentation, but very much out of context because I only had 45 minutes and I had to focus on a particular section. So that was certainly a good experience, but presenting the material in context, as we're about to do right now, I think is much more valuable for you, and it makes a lot more sense to me. As many of you know, I used to and I still do present a lot of information, but now more so than ever, my material is very organized, and I think it'll help you grasp the material easier and therefore apply it clinically, especially now that I have this acronym that maybe some of you have heard of by now. So we will go through this material and enjoy our time here in Miami. These are pictures I just took this morning. I went for a run, which usually means going barefoot for me. And here we are about to go through all this material. I want to orient you real quickly to the book that you all have. So you have all my slides in the book that you've got in front of you. You also have an excerpt from the most recent edition of my integrative rheumatology book, the section that deals specifically with mitochondrial dysfunction. We have a few copies of the integrative rheumatology book here. Came out to 628 pages, just published in January. For those of you who want to look at it, I don't know what the ultimate fate of those books will be. But the fate of this book is you get to take it home and take notes. And you've got everything that we're going to review today, which is almost 1,000 slides, in addition to a few pages of text. So, for example, if you look at the first section of the book, and I'm starting on looks like page 10, that's where we start the mitochondrial dysfunction information within a context of what I call the functional inflammology protocol. You're all familiar by now with functional medicine. You can certainly access some of my material on that in some of my articles. And so over the last couple of years, I've been focusing academically as well as clinically on inflammatory disorders. And so I may have coined the term functional inflammology. And so that's the protocol that we'll go through today. We'll do that in the first 3 hours. In the second session this afternoon, we'll go through mitochondrial dysfunction in particular. And then in the last part, we'll go through clinical applications. So again, referring back to page 10, just to get you oriented to the material that you have, which is about 400 pages total. You'll see on page 12, I start with dysfunctional mitochondria. That's the fourth part of my protocol and our focus for today. You've got a nice picture of mitochondria there, the same picture that's on the cover. And then I go through like the whole energy production pathway of glycolysis and alternate pathways and pyruvate dehydrogenase, Krebs cycle, and electron transport chain. Those are words that you all know, but you may not have heard them since you were an undergrad and first year of medical school. So we're going to focus in on some of that material today. And you'll see how clinically relevant it is, and you'll also see how it helps us to understand why certain things work and why certain things that we've been doing for a long time, how do they work, and how can we make sense of nutritional interventions in a way that's so different from pharmacotherapy with drugs, right? So for example, we'll talk about CoQ10 today. How is it, and we'll talk about melatonin for that matter. So let's talk about melatonin first. We could pick one or the other, but we're going to talk plenty about CoQ10. So how is it, for example, that melatonin has clinical effectiveness in such divergent conditions and different problems, like how does it help sleep? How does it help with inflammatory disorders? How does it improve the clinical outcomes in patients with fibromyalgia, migraine headaches, cancer? I mean, how does one substance, in this case a hormone, how does it create all those divergent effects? We could say the same thing about CoQ10, which I just mentioned. How is it that CoQ10 is effective against diabetes, hypertension, migraine headaches, fibromyalgia, allergies? Like, how does all that happen? Even 2 years ago, I don't think we understood it very well, but I think now, and the answer is quite obvious, it all relates back to mitochondrial function. So we'll talk about that. And I think, as I was just starting to say a moment ago, I think by the time we get through this material, you'll see that so many things that we didn't understand even 2 years ago now make sense, understanding them within a model of mitochondrial function and dysfunction. So you've got all my notices. This is being recorded, and that's great, because we'll all have access to it later. A few disclosures, you've got those. So let's go through this. This is a very interesting case that I actually presented in one of its most recent forms here last year in April. In fact, I was on the stage, literally, we were taking a lunch break, again here last year in April, when I got the lab results from this patient. Really interesting case. So this is a patient who came to me in March 2012, which is the same month that I updated this protocol. So she was the first patient to experience it. Rheumatoid arthritis, treatment resistant, had limited financial options, but had already gone through really the usual gamut of treatments from a rheumatologist that you would expect, right? Prednisone, methotrexate, sulfasalazine, Plaquenil, and then biologics. The typical protocol, which we'll talk about later. And you can see her CCP antibodies are greater than 250, right? So we don't know how high they are, maybe 300, 400, 600, but we know they're greater than 250. She's got rheumatoid arthritis. So I treated her with the protocol that we're going to go through today. And then, so here we are starting in March. 9 months later, her CCP antibodies came down to 195. I was happy with that. And then, as I was on the stage presenting this material here last year, April of 2013, we retested her CCP antibodies and they were down to 54, right? So that's not simply, and she's virtually asymptomatic. That's not simply treating her rheumatoid arthritis, that's reversing her rheumatoid arthritis, right? Which is impossible, because we all know that rheumatoid arthritis, just like diabetes, right, is a chronic disease, and patients have to submit to it for their lifetime. Obviously, that's not true. You all know, this is in the notes, I won't go through that now. You've got it. I've published a lot of articles, as was mentioned in the intro. A lot of articles, a lot of books. Okay, so we're going to look at a new way of managing a lot of different conditions. And so how can that be? How can we have one protocol that we can apply to so many different conditions? Well, you'll see that we're going to look at some common denominators, so to speak, in a lot of different conditions, and that's what I've outlined in the protocol. We're going to learn how to apply that, and you're going to see how it makes sense to apply that to so many different conditions. You know, like if we look at things from our medical perspective, we treat hypertension very differently from how we treat fibromyalgia, right? But with the application of this protocol, you'll see how we would use the same protocol to treat hypertension, diabetes, fibromyalgia, how it all kind of makes sense. So how does it make sense? It makes sense because I look at a lot of research, and what I look at, you know, like for example, I might look at a couple hundred articles per year. Last year, I think I looked at about 1,500 articles. And so when I'm going through the data at that rate, as I have been doing for about 20 years or so, 10 years, 15 years, what I notice in the research are patterns, not simply an isolated article over here that says, you know, CoQ10 is good for hypertension or diabetes or whatever, but I start to notice certain patterns. And so what I did in 2012 was I started to organize those patterns into this protocol. And as I was doing that, I started to prioritize things into what do I think is most important and what do I actually do with patients. And that's how I came up with the protocol that we're going to go through today. So my goals for this are to identify and discuss each of those components today. I'd like for you to be able to memorize those, which I'm sure you can do quite easily. But, you know, in my case, for example, I've been kind of a student of the educational process for a long time, right? So when I was a little kid, I think I was in the 4th grade or 3rd grade. To be specific, it was the 3rd grade. No, I'm sorry, 4th grade. Mrs. Hall's 4th grade class. That's when I decided to become a teacher. I remember the exact day, actually, because she insulted my friend Robert and took away his playtime because he couldn't get this question right. And Robert was my best friend, right? So I got upset with her because I thought it was her bad teaching that was making him not get the question right. And so I thought, you know, if I were the teacher, I would teach him so he could actually learn. So that's when I decided to become a teacher. So, and that's why I spent so much time in school, you know, going through 3 different doctorate programs. Part of it was, of course, to learn whatever they were trying to teach me. But another part of it for me, honestly, was just to kind of apprentice myself to the educational process and see how it could be done and how it could be done better. And that was my route. So I'd like for you to be able to identify these, recite them, and explain them, because obviously we have to be able to explain things to our patients stereotypically at an 8th grade level so they can understand it, and I think you'll be able to get this by the time we go through the material. I always have a lot of information. You've got all the notes. Most of us have been through one version or another of medical school. Unfortunately, we don't learn a lot of nutrition there, and you all know this. It's a problem that is well documented. It's a problem that hasn't changed. It seems to be a problem that's not going to change. But if we go through medical school and all we learn how to use is we learn enough physiology and biochemistry to be, adept at using drugs, then what are we going to do clinically other than use drugs? Probably use drugs in labs and diagnostic tests and procedures. And if you look at this article that was published in the British Medical Journal in 1999, that's exactly the way that family practitioners practice, and typically other specialties as well. We aim for a diagnosis when patients come into us. We have a connection with what's been approved as the appropriate drug, and we prescribe that drug. But what we should be doing, and what I'm sure you all know by now, what we do in functional medicine is we try to look beyond their diagnosis to actually understand what's going on, right? And then we try to fix the problem instead of just medicating the problem, with all due respect for medications, some of which I love and some of which I don't. But I do have an appreciation for pharmacology. And I use drugs in my practice. I'm not saying I don't use drugs, but I'll show you which ones I use and how I use them. For example, how many of you use, assuming most of you are either family or you've all been through at least enough family medicine anyway, but how many of you use ACE inhibitors or beta blockers or angiotensin II receptor inhibitors in your practice, right? I kind of like those drugs, but the question I would ask is, do we really know how those drugs work? So for example, if you're using an ACE inhibitor or an angiotensin II receptor blocker, the ultimate goal with that is to block the action of angiotensin II, right? And that's how we lower blood pressure, and in some cases, of course, especially for those of us who have practiced a little bit of urgent care or emergency care, which I love, the goal is to lower blood pressure, and those are the drugs that are approved, and that's what we use in those situations. Again, sometimes it's completely appropriate. But I think the question we could ask is it appropriate as a lifestyle treatment? I think we all agree it's appropriate for acute care, but is it appropriate for long-term chronic treatment? So let's go a little bit farther. If the rationale pharmacologically and medically is to use those drugs to block the action of angiotensin II at the receptor, ultimately, whether we block its formation or block its reception, then I think the question we should ask, or the question we could ask, is, well, how does angiotensin II actually work? If it's a vasoconstrictor, how does it cause vasoconstriction? We all learn in medical school angiotensin II is the most powerful endogenous vasoconstrictor. At least that's one of the things I remember reading. Okay, well, how does it work? How does angiotensin II cause vasoconstriction, which leads to hypertension, which leads to increased risk for myocardial infarction, stroke, and disability, atherosclerosis, right? What's the link there? So what I'm going to show you as we go through this material is, if you understand how angiotensin II works, you'll understand how we can bypass that whole problem by using nutritional interventions. This is one of the hospitals I trained in Texas. We had a McDonald's in the lobby. Total disaster, right? I mean, what is McDonald's? Well, here's another hospital I worked in, and this was the cafe, where we had posters advocating vegetables, but we sold soft drinks loaded with high fructose corn syrup, and all the foods were cooked into oblivion. And as you can see there, those are French fries. So what's the problem with French fries? Three main problems. First of all, they're nutritionally depleted. They basically don't have any nutrients. So it's just empty calories, as the saying goes. And what else? High fermentation, so they promote bacterial overgrowth of the small bowel. And acrylamide. Yeah, exactly. So when they're fried, you're going to get a big load of advanced glycation end products, lipid peroxidation products. It's a disaster. And yet, that's what we're advocating for the faculty, staff, and patients of this hospital.